Good evening, everyone. Thanks for joining. My name is Russ Ryan and I work for MEDTRONIC. And tonight I have the pleasure of hosting this webinar where you'll get to hear from Dr. Ramzi Aboujaoude. Dr. Aboujaoude is an award-winning board-certified OBGYN and urogynecologist at the Urogynecology Center at Virginia Physicians for Women. As a urogynecologist, Dr. Aboujaoude has completed additional training and experience in the evaluation and treatment of patients with urinary incontinence or leaky bladder, pelvic organ prolapse or dropping of the vagina, uterus, cystocele and rectocele, and fecal incontinence. Dr. Aboujaoude is passionate about improving women's quality of life and helping guide them towards individualized treatment options, which may range from physical therapy to minimally invasive surgery. Having continuous change and modernization is also a source of his love for his job, and he enjoys the variety of work each day brings. He also enjoys seeing advances as doctors are able to help their patients with less invasive procedures and with more efficiency. So with that, I am going to turn it over to Dr. Aboujaoude. I'm going to get out of here and let him tell you a little bit more about today.
Hi, everyone. I'm Dr. Aboujaoude. I don't know if you heard Ross presenting me. I'm surprised. Sounds like a great guy. But so I'm a urogynecologist. Let me define a little bit very fast what's urogynecologist before I start. Back in the years, we know that there is a urology as a specialty, and there is another specialty, we call it gynecology, and definitely you're aware of this. The gynecology is when we take care of women in general, urology when we take care of kidney, bladder, anything related to this type of problem. Now, the urogynecology is a special set. You can be an OBGYN, and after that, you go for another training now for 3 years to be a urogynecologist, or or you can be a urologist and do another 3 years to learn a little bit about everything related to this specialty. So really, it's a good specialty. Unfortunately, we don't have a lot of subspecialists in anywhere. We are in high demand. But the good thing is we have improved a lot of things. And one of them is the treatment of urinary incontinence. So definitely, I'm far from being formal when I present my presentation, because I'm not here to tell you what you can see on Google, that's for sure. I'm here to discuss. So instead of talking for an hour nonstop and get bored and half of you will be tired, it's the opposite. At any time you want to ask a question, we have the technology, we can find where is the question and I will answer you. Don't worry about that. Even if you are now around more than 40 or 38, I see, definitely we can do that. The bottom line here is not to listen to me. The bottom line is to answer your questions. You're here, you have questions, and I'm planning my best to answer all these questions. So if we start very fast, urinary incontinence and fecal incontinence, those are the main topic we're going to talk about today. You will be surprised that 50% of the people now, even in 2022, are 20% of the in 2022, 50% of the patients are not sharing this problem, not only with their doctors, even with their family member. And this is a high impact on the society. So first of all, we still consider this problem as a taboo, and in my opinion, it's far from being taboo. We have to put this behind us. We have to fix the problem. And number two is 50% of the patient I'm going to add don't know that there is a treatment for that. And this is the problem. It means we have a problem, we have a condition, we don't know, we don't want to share it with our doctors, and we don't know if there is a treatment or not. And the good news you're going to hear today, yes, there is a treatment. There is a treatment, and we're going to go through details today. So what we're going to talk about is very simple, very easy. Want to talk about the bladder and the bowel, but I won't lie to you. The bladder is my #1 topic because it's more popular. Most of the patients have bladder leakage, and we'll talk a little bit about the number later on. We're going to talk a little bit about how we make our diagnosis, our treatment option, and definitely I want to put a little bit more, I want to spend a little bit more time on the INTERSTIM, which is kind of a cool treatment. I would call it cool, which is not, it's a new idea, although it's been on the market for years, but this is a new way to fix problems. So that's why we are here today, actually. So if I will start here with this slide, I don't know if you're able to see, 1 out of 6 adults in the United States have overactive bladder. So it's a huge number of people have it now. Not only that, if we take the female patient, 1 out of 3 patients have urinary incontinence. It means they leak. They can have overactive bladder, and we're going to talk a little bit about it. Or they can have another problem with stress incontinence. I will talk about it. But 1 out of 3 patients are having problem with leakage. And can you imagine half of them don't know that there is a treatment? And that's what we are here today. So is it normal to have leakage? Is that, I'm getting older. Oh, this is an aging process. We hear this all the time. Live with it. My mom lived with it. So deal with it. This is not normal to have urinary incontinence. It's very frequent. We see it all the time, but don't confuse frequent and normal. I'll give you an example. Blood pressure. How many people have blood pressure? A lot. Is that normal? No. But we see it all the time? Yes. Do we panic? No. Can we address the problem? Yes. And let's talk about incontinence or urinary or fecal incontinence. Are they normal? No. Are they frequent? Yes. We see them all the time. Can we do something? Yes. And that's why we're here. So if we talk a little bit about incontinence, urinary incontinence, we have 2 problems. One of them is, and everybody knows about this, if you cough or you sneeze and you leak, if you jump and you leak, if you do any typical exercise and you leak, we call it stress incontinence. It means you put pressure on the bladder and you leak. It means there is some problem going on, not holding very well. This stress incontinence, usually we address it with type of physical therapy, exercise, surgery. That's a little bit not our topic today, but I want to consider this as a major problem because some people have the overactive bladder, which is a little bit different. Overactive bladder is when the patient is sitting and has the urge to go to the bathroom. And sometimes she is not able to make it to the bathroom. And that's what we call overactive bladder. Now, if you don't make it, we call it urgency incontinence. If you're going to the bathroom and you're not able to make it to the bathroom and you leak, that's an incontinence. We call it urgency incontinence. So this is nothing to do with cough and sneeze and leak, but unfortunately, they come together. So if we give you another example, if you drive a car, and actually the bladder is like, has an engine, okay? If we have a problem with the brake to stop when you cough or you sneeze and stop, the braking system, that's the stress incontinence, and we're not talking about it today. I'm gonna close it today here. But what we're gonna talk about today is the other part, where you're sitting and somebody is pressing on the pedal and the car will start by itself. And that's overactive bladder. It means the bladder is not waiting for us to give the order to go to the bathroom. It's the opposite. Will give us this urgency and start emptying without our control. This is what we call overactive bladder. Now, the bladder in general, if you look here on the screen, how the bladder works, make it very, very, very easy. Imagine that there is a center in the brain and a small center close in the spine, and there is a connection going to the bladder. All right? The bladder will give you a signal. I'm full. When the bladder is full, you feel it. You control the bladder. You tell the bladder, I'm not ready to empty now. You have time to go to the bathroom, and you empty. Imagine that the signal is wrong. The bladder is not full and will give you a false signal, or the bladder starts contracting without your control. And that's exactly what's going on with most of the time. The bladder is out of control. If we go a little bit to the bowel, unfortunately, we have something very similar. The brain controls the last part of the bowel, the rectum. I don't want to go in detail, but imagine that the stool goes in this rectum. You have a distension. When you have a distension, the brain will notice that, will send a signal and say, okay, let's close the door and keep it closed. And what happens if the brain doesn't have this control and the door doesn't close on time? The bowel will contract and let the stool go out without your control. And that's what fecal incontinence. So two different problems. They are very well connected because they come from the same center in the spine. So they are very well connected, but they are separate at the same time. So our topic is the overactive bladder and the fecal incontinence today. What are the causes of incontinence? 100 of them. I wish I can tell you one thing. But if you talk mechanical, bladder drop, vaginal delivery with some stress in the vaginal area, traumatic surgery, radiation, pregnancy, anything can affect this area, can stretch a little bit this area, will affect the nerves, will affect the support, will affect everything. Can we do one thing to prevent this problem? There is 100 ways to prevent things from happening, but at the same time, there is no good way to prevent it. So because there is multiple causes and there is no one reason to give me this problem, it's very tough to control it. But if we go first of all here, for example, we talked about eat and drink. Give you an example. We know that caffeine will stimulate your bladder. If you're drinking coffee or you're drinking alcohol or you're drinking tea like I'm doing now, I know that they have caffeine and gonna stimulate the bladder. So if I cut down on caffeine, I might get better timing to go to the bathroom. So we know this part, but there is a lot of things that we cannot control. So again, to summarize the bladder problem in general, there is a stress incontinence, and I told you that we're not talking about it. That's when you cough or you sneeze and leak. There's another problem, which is the retention. Very broad subject. It's mainly when you're not able to empty all the way your bladder, but there is different ways to fix it. Sometimes it's mechanical when you have a kink in the urethra or there is something. When it's a man, it's totally different. We're talking prostate, it's out of subject. It's not our subject today. But sometimes imagine that the door that opens and closes has a problem. The mechanism behind it is not working well. That can be a problem and can be addressed today. And the third problem is the overactive bladder. So we kind of know very well that overactive bladder, this is the topic of today. We're going to talk about the treatment, urinary retention. It's when it's electrical problem. We're going to talk about it, stress incontinence. In summary, it's physical therapy and sometimes surgery, but it's not the subject for today. So we talked again, stress incontinence. I don't want to repeat that. Urinary retention, as I told you, it means you're not able to empty your bladder, but be careful. If you have a surgery and you put a sling and you're not able to empty after that, that's a mechanical problem. If you have a big prolapse and the bladder has dropped and everything is kinked and you're not able to empty, that's a mechanical problem. It means there is something kinked. We go and fix it, address it surgically or with the procedure, and we fix it. It's not electrical. But the problem, if you go, you check, everything looks fine, looks great, no problem at all. But the problem is you're not able to empty. So the door is not opening and the bladder is not squeezing at the same time. And that's where the problem is. And this is the discussion that needs to be discussed today, because it's the same treatment for leaking and retention, and you will be surprised. Overactive bladder, I repeat one more time. It's when you have, I call it fun, but it is nothing fun. F-U-N. F, it means a frequency. You go very frequently to the bathroom. U, it means urgency. You have a lot of urgency to go. And N, we call it nocturia or nighttime. You wake up in the middle of the night and you go very frequently. So this fun factor is not fun at all. And that's what we need to go after it and address it step by step. The fecal incontinence, that's a different story. Fecal incontinence can be related to two problems. People who have diarrhea, sometimes it means the stool is coming very, very, very fast to the door, and the door does not have time to close on time and let the stool go. And this is a problem, and we see it all the time. We always hear people with very soft stool or diarrhea, they leak. Needs to be addressed. And the other problem is when you have this passive incontinence, when you wipe and you see, or you check and you see already your underwear is not clean. And this is another embarrassing problem, especially when you don't have a warning. You're sitting, you have a party, and in the middle of the party, you have it. And this is another problem that needs to be addressed. So good news. Always there is a good news. Treatment can get you back to living your life. I'm very serious here. Yes, treatment is very important. Even if there is no 100% cure, at least we talk now satisfaction. How much the patient are satisfied when they get the treatment. We ask them how much you improved. They tell us 90%. Is that a cure 100%? It's okay. It's not a cure, but it's 90% improvement. Definitely you control, instead of leaking every day, now you leak once a week. With extra measurement, you can make it to any party. You can do any sport you want. That's great. That's great. I think that we can make anyone's life better, the quality of life better, even if we're not curing 100% the problem. So how do we manage overactive bladder or fecal incontinence? And this is very important. We always I know that Russ likes to call it the pathway, or actually, there is a path between diagnosis and advanced therapy. There is different steps. So if you come to me today and you tell me I have overactive bladder, I put you, even if you don't see it, but you are on a scale, or you're starting step by step your treatment. You don't reach the top of the treatment if you're very satisfied with the first step. So how we treat patient. First of all, we're gonna talk about the lifestyle and diet change, everything related to no medicine. And this level of treatment, we like to call it level 1. It means when you come to me and you have overactive bladder, you leak urine, the first thing we're gonna say, okay, you cut down on caffeine, monitor what you drink, everything that you eat has to be very soft on the bladder. It means if you have a lot of spice in your food and the spice is bothering your bladder, possibly you need to change it. If you drink alcohol and it's not bothering you, it's okay with me, but if it's bothering you, change it. So some exercise, physical therapy, we have a combination kind of multiple treatment at the same time. They are mainly a lifestyle more than medication. And this is perfect as a first stage. If the people are doing fine with that, if my patients are happy, I'm happy. What happens if we're not there? We go to a level 2 treatment. And the level 2 treatment is usually medication. Before I go to level 2, I want to mention with diet with fecal incontinence, I always tell my patient, start fibers. Fibers will make your stool a little bit bulkier, but at the same time, they are soft. Instead of going fast through the door, now they have to, they stop a little bit and they don't move very fast. So it's perfect to give us enough time to close the door and don't let anything go. So fibers, start fibers without coming and asking any doctor. If you have fecal incontinence, add fibers. Medication. Medication usually, if I talk about the bladder and overactive bladder, everybody has tried medication. There is tons of them. I can divide them in 2 different types of medication. The first family, we call them the antimuscarinics. These are old version medication. They give you dry mouth, blurry vision, constipation, and hypertension sometimes. Not those, but they're good. And the problem, if we keep them for a very long time, you might end up with some memory loss, Alzheimer. So it's very good to have them, but I don't want you to be on them for 20 years. There's another type of treatment, medication, newer on the market for the last 10 or 15 years. And these medication, we call them the beta-3 agonist. Definitely they work a little bit different. They're a little bit softer, not 100% better on the bladder, but softer on the side effect. I will say it's a great start to a lot of patients, and we use it as a second level of treatment. So what happens if the patient are not happy with their medication? Most of the patients stop their medication because of the side effect. They are still leaking. They're not doing fine. And what's next? And that's where the most important part, and this is what we have today. And we call it the third level of treatment. The third level of treatment, I'm gonna divide it on 3 different options. One of them is BOTOX. You heard about BOTOX and you heard about the wrinkles. So imagine that the bladder has wrinkles, it's very tight, it contracts too hard. What about we go and we put some BOTOX inside the bladder and we cut down the wrinkles. Perfect. It works very well, but there is a catch. Number one, the bladder gets a little bit slower. So some people can catch a little bit more urinary tract infection. So it's not perfect. It's good for a lot of people. Half of the patient like it, but the other half don't, for only one reason. It doesn't work perfectly. Sometimes you can have retention. It means you're not able to empty. The bladder is getting very slow. Or you don't get better. So, okay, we did that. And some people, they have to go. It's a procedure. And you have to repeat it every 6 to 9 months. Some people less, some people no. Is that good for everyone? No. Is that an option? Yes. Very valid option. And I like it very much. So what happens if the Botox is not the right fit? Before we move to another one, who decides if it's Botox is good for you or not? And that's the good discussion you're going to have with your doctor. Is that good? We take in consideration if you have urinary tract infection before, if we feel that you're able to go through retention or not in case of retention. So we have to measure it, measure all this, the plus and minus, all the side effects before we go for Botox. Very valid option. I love it. It's very good. Second, another option, we call it posterior tibial nerve stimulation. So it's a little bit, I used to like it, but I stopped doing it for only one reason. As if you see in this picture, there is a needle that you put it here, you stimulate the nerve, you put this stimulator, and you come to my office once a week for half an hour for 10 to 12 weeks. Personally, I did not have a good success. It's a very bothersome for the patient to keep coming every week forever. They like it for the first 2-3 weeks and then they stop. So it is tough to be adherent to this type of treatment. It's not like one stop and you're fixing. You have to keep coming and coming. And most of the time, people stop coming. And that's why I wasn't very successful for only one reason. I had very hard time to find someone to come every week for 12 weeks to find out if they are doing better. Do I like it? If someone else loves it and tried it, I'm not against it, but I wasn't very, very successful with keeping the patient coming to my office for 12 times. And the third option, and I think, by the way, this tibial neuromodulation, it's a device that it's very small, that it's delivered by this company, MEDTRONIC. So MEDTRONIC is very well known with pacemaker, everything you can imagine, a huge company. So this is a small stimulation that comes and stimulates the nerve peripherally. But here is if you want to go through electric stimulation, the other option will be the sacral neuromodulation, which is another option. Some people love it, and some people will hate it. But let me explain to you how it works. So we talked about the overactive bladder, and we're going to talk about the fecal incontinence and even the retention, the three of them. This is an electric problem. It means the bladder is getting contractions all of a sudden without control. Okay. The same problem with the bowel is not closing on time, or the retention. The bladder the sphincter is not opening. The door is not opening to empty when we need it. So everything is electrical. What about if we go to where the nerve goes to the bladder? So it means in the back, it's not in the spine, in the back, very low. So don't worry, nobody gonna be close to the spine where nothing risk of like we're not going into the area where it can affect you walking or anything like that. No, it's down where only nerves. So if we go there, and we stimulate the nerve going from the spine to the bladder, and we modulate this nerve. And if we can have a control of the bladder contraction, sphincter opening, and the bowel sphincter of the anal sphincter control too, problem solved. So it's great. The idea is great. But how can we pick our patient, and how can we tell if the patient are right or not? We're not going directly to implant a device that gives you electricity at this area. The beauty of this technique is, I'm sorry. Okay, the beauty of this technique, we have a way to do it without committing to the problem. We bring it to the office, we'll put a needle just in the back, we numb this area, and we'll put a needle, and with the needle, we insert a wire. You're gonna be wired. It's a lead, and this lead will attach it, like in this picture, to a stimulator or to a modulator. Is like a battery inserted outside, and you're gonna carry it for 1 week. So that's perfect. We have a test for a week with a wire connected to where we want to stimulate it. And you can leave your office. It takes half an hour, local anesthesia. You can drive, you can do whatever you want, no restriction. The only one thing, we don't want you to shower or have a bath directly in contact. So you cover it, we tape it, and you can do sponge bath only for the time being for a week. This week is the most important week where we test your symptoms. I want to see if you're responding to the stimulation. Now, if you are responding to the stimulation or to the test, to the modulation that we're providing, and you're happy with this, at that time, we offer you a permanent solution. And what's the permanent solution? We take this device out, and at that time, we implant a small device. You saw it here. It's like, I don't know if you're able to see it, this one or this one. It's, I will say, this is inch by 1.5 inches, I think, 5 or 2 inches by 1 inch. This is the big one. This one, if it's like a USB port, is very small. Can be implanted. It's like a pacemaker for the heart. The same thing is very similar to a neuromodulation for pain management in the spine, but this time we put it a little bit lower under the skin, under the fat of the skin. So you feel it if you want to, but it doesn't bother you usually. And this one will be connected permanently with the lead to where we want to stimulate the nerve. This way, we are controlling the bladder and controlling the rectum. It depends what we have. The good thing is, that's a great success. If you read here, 89% of the people using MEDTRONIC bowel control therapy experience long-term success. Perfect. It's really good, almost 90%. And for the bladder is around 75%. But there is a bias. Don't forget that the people who are getting here are the patient who are getting to this device have failed already medication. So are not the simple one. The simple one who are responding to the treatment are great. They are not coming here. But the one who failed the medication is failure, did not get better, and they start leaking. And we tried this one, and we have 76% improvement. And that's the great. They are not the patient. We're not the first line treatment. We don't offer this as a first line, not at all. We offer them for almost the 30 or 40% or 50% who did not respond to the first line and the second line. And that's where we are here. So definitely they are for more severe, and still we are very acceptable treatment. Now you're gonna tell me, oh, what does it mean success rate? It means at least you improve more than 50% your symptom, which is good. Give you an example. If you wake up in the middle of the night 4 times, now you might wake up 1 or 2. So you have a good sleep. 4 times is impossible, but you might not wake up, and you will have to sleep. You can sleep now all night, and you don't have to wake up every hour, for example. So that's great. That's really great. So these are the two, I think, the two major problem here: fecal incontinence and overactive bladder with urgency incontinence. Great success, in my opinion. The good question: is this therapy right for you? I wish. I cannot tell. I don't know what's the problem. Where are you in your staging? Where are you in the first level of treatment, the second level of treatment, the third level of treatment? If you already failed 3 of them, where are we? Is the test done properly? The medication we're taking right? So the good thing is with MEDTRONIC, the INTERSTIM device, is you don't have to be committed. That's the good thing, in my opinion. So we try it for 1 week. If you're not doing fine, great, forget about it. If you're doing great, we put it. Now, when I say committed, we install it. You don't like it, we can take it out, but it takes another procedure, because inserting this device is a procedure, is a surgery. Well, it's a surgery under MAC anesthesia. It's even like sedation. You don't need general anesthesia, but you're going to have like a 2 inches incision to insert it. And we need to do it at the hospital because we need the X-ray. But can we take it out? Yes. If it doesn't work, take it out. But we don't want to do this. That's why we test you before. So we insert it. And we want to keep it. So hopefully it's the right treatment. And if it's right, if it works, really people are happy. Actually very happy. So I'm not sure if it's good for you or not. What's it? One of the patient who, here we have some example, but I have one of my patient who had a pelvic prolapse surgery, big surgery. We did a surgery and everything was fine, but she kept having this overactive bladder. And we tried medication with her, never helped. And she felt a little bit disappointed because she had leakage before her surgery. I found that she has prolapse surgery. I did her surgery, and all of a sudden, here we go, we're still leaking. So I offered her the INTERSTIM, and she had it inserted 3-4 years ago. I saw her not this week, last week, actually. That's why I remember. She told me, this is the best thing happened to me. And I would be happy to talk to anyone if they want to. At the same time, I saw a patient who did get better, but not 100%. I will ask them this question: would you do it again if we have to? They said yes, by far better than before, but not dry 100%, which is okay with me too. So I'm not offering you a treatment that's going to be 100% great to everyone, but there is a good chance to be good. I think I came to the end here. I don't know, Ras, are you here?
Yep, I'm here.
I'm on purpose, I want to hear questions.
Yeah.
And,
so thanks, Dr. Aboujaoude. That was fantastic. If you do have questions, down on the bottom of your screen, there's a Q&A icon. Go ahead and click there. I will be able to see those questions, and we can ask Dr. Aboujaoude, and we have a couple that have come in. So one of them is—
I can read them. I have them. I can read them if you want.
Okay, fantastic. Great.
I hear a question from one of the patient. And she said that the meds for incontinence is really over the budget. Are there any alternatives? Great question. And thanks for asking. The problem with the medication, that is the old generation medication, new generation medication. The newer are a little bit more tolerated by the patient. But unfortunately, they don't have a generic, and they are extremely expensive. I'm gonna name two. One of them is MEDTRONIC, the other one is Gemtesa. So they are very expensive. Now people do get better on them if they are able to tolerate the side effect, but unfortunately, the medication are not all the time covered by the insurance, and they are very, very, very extremely expensive. We're talking about $400 or $500 per month. So if you cut down $400 to $500 per month, the cost, and you multiply it by 5 to 6 years, like a device that we're putting, it's 6,000 times 4 or 5 is more than $30,000. So it's a huge amount of, even if you don't pay it, someone is paying this cost. Yes, the alternatives, if we go back to the old medication, and most of the time they don't do great, and there is some side effect. I will be happy to discuss it with you. But again, it's sad because the insurance company don't cover all the medication.
Yep.
Yes.
So before we go to the next question, I'm going to stop the recording. We're still here. We're going to take some questions as they come in. So don't go anywhere yet.